Thank you very much for this invitation. I will give a talk about real-world experience with prolacizumab in naive patient, actually. So this is a new molecule. I think we have talked about it maybe few of our colleagues before.
Hey, no. Sing.
Yeah, well,
Sing.
it's okay. We are
We are
accepted.
here to. It's the goal of the day. It's the central soundtrack. Don't talk about it. Sing.
Okay. Okay. Um, I know I will concentrate about the AMD because I have experience with AMD more because just we receive only the approval for diabetic macular edema very soon and we don't have that much follow-up regarding the prolacizumab. In UAE, we are actually the second country to use prolacizumab after United States. And I was the lucky, I don't know lucky or not, but to use also prolacizumab in the Middle East. So as you know, there is an Hock and Harrier that the one approval for using a prolacizumab as a 3 milligram for the patient in comparison to, 6 milligram as a comparison to 2 milligram. The prolacizumab is very small molecules. One of my colleagues already explained, I think you have done, right, about it, so I will not take much time on that. So prolacizumab delivers 12-fold more molecules than aflibercept on the same volume. So because of the small molecule weight, so in this amount, 6 milligram, you will have a lot of molecule available in the vitreous when you inject this about 0.5 milligram, 0.5 ml, which is 6 milligram. So it is 12-fold more than aflibercept. Key molecular characteristic, I think they have a development, high affinity, rapid penetration, long-lasting effect, and high systemic clearance rate. That's why they say there is no systemic side effect, but we found something what we call ocular side effect rather than systemic. If there is something wrong, you just correct me. I know you are concentrating a lot with me, please. So the first case, this is a 70-year-old male patient, not diabetic or hypertensive, known case of wet AMD bilateral. This patient is my patient for a long period of time. So I was treating this patient and he had ranibizumab injection between 2016 and 2019, about 14 injection. And in the right eye and left eye 66 injection. Last injection in the both eye was April 2019, lost for follow-up for more than 15 months. That's why you call this patient as a naive according to the definition. If the patient is not taking any medication more than 6 months, you can consider this as a naive patient. It is not that clearly a naive patient without any medication, but he was treated with anti-VEGF ranibizumab for a long period of time, but loss of follow-up for 15 months. So the visual acuity when he attended the patient, he was 0.5 without correction, and there is no improvement. The left eye counting finger at around 50 centimeter. Slit lamp was very early cataract, intraocular pressure within the normal limit on the high level. So on the fundus, it was, as we know, for me, it was already treated neovascular AMD. And we found that the central retinal thickness on the right eye 700 and left eye 600. Then I suggest this patient because we lost a follow-up for more than 15 months and we have the chance to get medication actually free. And this patient was non-local. You know, in UAE, we have those they are expect. They are not all of them can get medication like local people. Local people, they are completely free. Expect either they are have an insurance or they are whatever they have to buy or something like that or anyway. So this patient was not insured, expect, and I want to just to help and explain for the patient what is going on about these new medications. This is the OCT of the left eye pre-injections. I think you can see now this patient here. Okay, and this is the video. Can you play the video because I think it's difficult from here to play the video. Can you play the video, please? Okay. This is just to show you how is the central retinal thickness, and it will reach a very huge number of central retinal thickness. You can see it by the video now. That's wet AMD, very clear. Okay, you can stop. So next one. So we give the patient, and as you know, this patient was having the left and right. The left eye, I select the left eye because it was the weakest eye, because it's the first medication to use. There is a threat of intraocular inflammation. In case there is something happened, it will not be a big difference because counting finger for 50 centimeter or hand movement, it will not be that much. That's why I select that weak eye to see how the effect it will be and if there is improvement of the vision, if we have any inflammation or not. In 1 week, just left eye improved to 0.05 and the tension with a normal and a very, very strong drying of the macula. This is the things new about the new molecules. Okay. So this is how it is. Sorry. It should be one by one. Anyway, it is, you can see, I think it's very easy to see or to know the difference. But anyway, I will show you now the video. You can see, you imagine the first video. I show you the video just because for curiosity, you need to just document what are the effects. I think you can see how it's completely within just 1 week. Okay. So this is a comparison also. You can see this is before injection, and this is just 1 week after the injection. It's 200 only central retinal thickness from 600 within 1 week. And also there is an improvement in the visual acuity to 0.05 from counting finger only in the front of the face or 50 centimeter, which is a very good achievement for the patient, all the patient of the AMD. They are having a very bad visual acuity. They are depending on their family whatsoever. So this one, it makes the life different. Sometimes some patients, there are no improvement in the visual acuity itself, but in only the type of vision or the quality of the vision. Sometimes the patient, he is becoming very happy. I see the vision is the same, but he is saying, no, I improve. And that was the quality of the vision, because when we are decreasing the reduction of the central retinal thickness, there will be little bit improvement in the maybe oxygenation whatsoever, and so that's why they will have a very nice improvement in the quality rather than vision itself. But here there was an improvement in the visual acuity itself. So this is 1 month after the injection. I brought this patient. Usually in ordinary we are not bringing 1 week, but because we are using a new molecules and we have a history of intraocular inflammation, so we have to take care about that. So the patient improved even more after 1 month, 0.1. Tension was normal, and you can see this OCT 156 from 600 within 1 month and 1 injection. You can see this is how it is after 1 month of pralucizumab. Completely reduction of the central retinal thickness and drying of the macula. Okay, this is a 3 month after the third injections. So we follow the patient. So after that, when I find the patient is very improving in the vision, there is a reduction in central retinal thickness, we go for second injection and third injection as according to the Hawk and Harrier study. And the vision is stable on 0.1. The pressure, it was normal, and also the OCT. So after 3 months after the last injection, this is also the result. Is it stable? We don't need, maybe only we have to repeat now every 3 months or not. Okay. This is the OCT video 3 month post third injection. Completely dry of the macula with improvement of the visual acuity. What I'm showing here this is the first experience. Some cases there will be not everything is magic, but we have to show the good things at the beginning at least. Okay, this is the second case. Same patient. Now I become comfortable. There is no inflammation and the improvement on the visual acuity. And that eye, it was now 0.05 vision before the injection, like here. And the central retinal thickness about 700, more even than the left eye. This is the video before. You can imagine how is the central retinal thickness. Okay. And this is OCT also after 1 week post-op. There is still not the same the previous one, but there is a reduction whatsoever. And there is also improvement in the visual acuity, even more better than the other one. It was here 1 month. It is 0.25 intraocular pressure with a normal and become 200 central retinal thickness. This is the vision and the OCT. And this is the video after 1 month. Um, this is the comparison. This is the patient before injection, just 1 month, and this is after 1 month of first only one injection of producisumab. So this is a very good things that we are going to talk about unmet need. One of the most important for unmet needs, this one, you know, one injection, drying, improvement of the visual acuity. You have a compliance with the patient and the other one. So this is a completely different things that we have it. So this is 1 month post the third injection now. I give you after 3 injection, almost stable, and you can see almost 145. And this is the video. Very, very minimal and completely drying of the macula. Even sometimes you think, why I will do another more injection, but 3 months after that, we have to do and check if we need or not, or we can extend. But mainly in AMD, they are extending up to either 8 weeks or 12 or 12 weeks. Okay, this is the third case. 70-year-old male patient, diabetic for 12 years, hypertensive, hyperlipidemia, lost follow-up of the patient for 5 years. Then the vision, he came after that, visual acuity on the right eye 0.3, left eye counting finger. Fundus, there is right eye, dry macula, dry AMD. This is, I think, I will send it to you. This one you can deal with him. And the left eye is with AMD, and plan also be of view for the patient to give in the left eye. And this is how it looks like in the beginning, and this is how it is the OCT. This is 2 weeks now. We are not same as we start. We little bit more confidence. So you start giving only 2 weeks, not 1 week. Later on, we are giving only after 1 month follow-up. So we are actually teaching the patients about everything. If he feel anything that can suggest any intraocular inflammation, he should. I give even my mobile number to all patients. They can call me anytime. So I have to follow them. And this is after 2 weeks is completely dry. This is 1 month. He improved little bit, not that much, but there was an improvement. And this is the fourth case. I will be very fast about the last 2 cases. I just want to demonstrate the first one, just to give you a more idea. This is an 8-year-old female, hypertensive, had both eye, a Avastin injection before 4 years. On examination, counting finger in the front of the face, and had movement in the left eye. Anterior segment examination, she is pseudophakic and left eye dense cataract. Intraocular pressure normal, and then right eye with AMD and left eye no view because of the dense cataract. So we treat the right eye, and this is how it was the pre-injection. And this is after pre-injection also, and this is the video. I hope it will work. Can you make this video work, please? Please. You can see it's very huge. It reached about 800 or something like that. Very, very huge central retinal thickness. Okay. This is visual acuity. It's the same. You can see there is some scarring in this patient. There will be maybe drop or reduction of the central retinal thickness, but most probably it will be difficult to improve vision that much. But as I told you, sometimes just improving only the quality of the life for this kind of patient, it's make a huge difference for them. This is a right eye counting finger. The central retinal thickness decrease. This is only 1 week. And this is visual acuity, OCT, also 1 week. Okay, please. Can you play it? Okay, let's go to the, okay. You can play this one. This is OCT 1 week after first POV. There is a lot of reduction in central retinal thickness, but most of you, they notice that there is a little bit improvement in the visual acuity, and mainly on the, and this one I didn't actually, they are, I get one free sample, but I couldn't get more, so we couldn't do anything about to continue on the same. So only one injection she received. This is 1 month. It is the same counting finger. There is a reduction a lot in the central retinal thickness. You can see. I think it's very easy. I don't think this is a video. This is the last one. Um, there is a lot also of reduction. You can compare it how it was before and now. Anyway, just I show you this one because they are a naive patient, and I don't want to take a lot of your time of this one. Just showing a different type. This one, I think she get a second one. So the take-home message from this one, that in early real-world experience with brolucizumab, OCT biomarker shows good improvement. Brolucizumab demonstrates better control of fluid and improvement in visual acuity in a patient. If there is any question about the intraocular inflammation, I'm ready to answer that. Whatever you want.
Yes, maybe. Well, what is important about this drug is that it makes it is a real dryer. I had my experience. Maybe I can tell you later, but the problem is the inflammation. And you said, well, maybe we can talk later about inflammation, but we all have in our mind the inflammation issue. Did you have any inflammation case? No.
I didn't face any inflammation. But also the same, the main things about the inflammation, we are not afraid of intraocular inflammation at all. We are only about the ocular vasculitis,
Yes.
which is less than 1%, or 0.1% like this, or you can say 1% vasculitis. But intraocular inflammation, anterior uveitis, whatever, you can manage, and you can give,
Yes,
that one. So in case we have like this one, also now I think the approval for treating patients with brolucizumab with diabetic macular edema, they didn't find this one. The approval study, they didn't show any difference between aflibercept and brolucizumab while we are treating the diabetic macular edema.
Yeah, that's.
And
I
there
think
is a
it's
question about this one, and there is, I think, most of us, they know about post hoc analysis they have done about that.
Rodrigo, can we just press on so that we get all the talks, and then we can go for the discussion later on at length. So, Ahmed, would you like to continue with your second talk?
As you like.
And
Whatever.
can I request the audience to save their questions for later, and the discussion should be amongst ourselves, and the whole house should be involved.
Shall
Thank
I
you,
go?
Ahmed. Let's carry on.
Okay, so we will go to next talk. It will be unmet need in management of DME. If you want, I can say it with one word, and I finish it only, just one word. Unmet need, either patient or governmental or the doctor himself. And everyone have the same. So we'll go very fast about that one. I will not go. This one is diabetic retinopathy. Already we mentioned it in many. But here I want to see how big is the problems that in 2000 something, it will be only 460 millions. It will be increased by 2040 to 630 million. They are differs from one. They are not the same number. Sometimes they are, say, 630, 40, whatsoever. But there is a huge number that increasing the percentage of diabetes. And our area, one of the most major area, they are having a high percentage of diabetic retinopathy and diabetes, and then the complication diabetic retinopathy, diabetic macular edema. I think because we are becoming a lazy, everyone having his car, no walk, many things happen, so percent of diabetic increase. The same, and this is the one. So either we have a patient perspective, or we have a healthcare system perspective, or physician perspective. This is the most important unmet need. I will concentrate about, but it could be patient and physician itself. The compliance is one of the most important points that we need. Most of the time we are looking for any treatment that to cure the disease. And this one is not possible. As the diabetic is there, so the complication, it will be there. But this is not our job. It's job of the internal medicine to find a cure for diabetes. Then we will forget to treat diabetic macular edema or diabetic retinopathy. For us, the most important is to recognize as early as possible, to treat as early as possible, and to have a patient to select the type of medication that you have to give for this patient. Because sometimes the patient is compliant, some patient they are from rural area, they come to to the town, they cannot come every 1 month. Sometimes they are not, they don't have, they cannot pay for that, is a cost-wise. So there is a lot of reason, so you have, from that you have to select your type of medications. Now there is nothing to call, I will give steroid later on or not. Even sometimes maybe you are forced to give a steroid. I have here a lot of, some talks here about subtenon giving a steroid. Why? Because we are trying to minimize the cost on the patient and also to minimize the side effect, and it's very cheap. And most of the people, or most of us, when the Ozurdex came, we are asking, why not use the other one? What is the difference to give one by 6,000, or it is in our area 6,000 dirham, which is about around $2,000 or a little bit less. I mean, you can say $1,800, $1,700. And the other one, it's not, doesn't cost more than $10, the medication. So we have to go through what is the most important for the patient and according to each patient alone. Treatment compliance, they are mentioning now, those they are compliant, you can see if in the first, between 2008 and 2011, the respective study, they found that they are non-compliant in about 70% of the patient. In the next, after that, 2008 to another study, they mentioned about the same. Just a little bit different in the luminous, they found that it is almost 50-50%. But at the end of the day, the compliance wise is very, very high, and there is no complaint from the patient. And most of the study that show, most of us, we are not giving more than 4.5 of injection per the first year, which is, we have to give more than 8, 9. I mean, the average, most of the time, is very less than what it should be. And this is also another real world experience in the clinical trial, something, and the real world, you can see it's completely different. And you can see here, it is, in the right side, you can see most of them, as I mentioned, 4.5, 4. All of them, they are just 4, which is not equal. Here you can see in the clinical trials is completely high, 9, 11, 7, which is different than what it should be. The DME disease burden, also this is very important, according to the management, comorbidities, because we are not treating only diabetic retinopathy. This patient can have a lot of complication and need a lot of care from different aspects. So if we want to come to the last, we can multifactorial nature of DME treatment and unmet needs. So we are looking for drugs that we can use in a very long period of time, 2 years, 3 years, 1 year, anyway, whatever. We need that medication to have a very good response and effect, and also to be a safe. So efficacy, safety, and long duration or durable. This is the most important, or what we are looking for as an optimal opportunity exists now. Now they are talking about what we are having, brolucizumab, as I mentioned, and faricimab, also another medication came in the market, and now we can give every 16 weeks, and this is a very good achievement. We are looking more and more for a better. So our anti-VEGF, in the beginning, it was something only just in the earlies, we are giving only laser, and the era of anti-VEGF, we are improving the visual acuity rather than only halting the deterioration. And most of the time in era of laser, we are only 40%, we can give some hope, and or we can stabilize. 60% of them, they are even deteriorating even after the laser regarding the visual acuity. Okay, so this one we have mentioned about this one. Anti-VEGF therapy have redefined the care of patients with retinal disease. Okay. So this is a case one. I don't know if there is a time or you want me to stop because. Okay, I can continue.
You can take a couple of minutes.
Yeah. Okay, just this case I will show you. This is a case because I try to select the cases with non-compliance just to show you how the things is going on. This is a 50-year-old male patient, no case of diabetic for 15 years, hypertensive hyperlipidemia, vision on the right eye 0.6, on the left eye 0.5. anterior segment very mild cataract, mainly in the left more than the right. So pressure with the normal and fundus examination both are severe non-proliferative diabetic maculopathy. And this is the OCT of the patient. So that was seen patient on October 2020. So due to what? Due to era of COVID, loss of follow-up with this patient since April 2020, and then restriction of the surgery in our hospital that days in the beginning of the era of COVID, everything is completely locked down. So we discussed with the patient to give long-acting treatment for DME, and that's why we give fluocinolone acetinoid on 8th of October 2020. So I feel if I didn't give this one, he will be continue at least 1 year, I will not see him. This is one of the way of solutions, so we are looking for something that can work for a long period of time. This is OCT on, just we saw him once maybe on November. Then this patient, loss of follow-up of the patient till 20 of April. So as we anticipate, this patient, just one time we can see, after that, more than 6 months, we didn't see him. And after that, when he came, the vision is okay. There is little bit slit, yani right eye still more, I mean posterior subcapsular, intraocular pressure, good. And even the OCT is very nice when we are giving. You can see here, this is on April. It will not be a lot of appreciation, but I think if you can look here down on the map, you can see the difference on the retinal thickness. So plan to top up even this one, this patient with dexamethasone. I know, I mean, he don't like to give a steroid, but I will give, I give a steroid, top up with steroid, because this one, it will take a long of time. Also, no need for follow-up. So follow-up done on 30th of May, the vision is also become less because now we are facing the cataract of this patient. Follow-up done also in the June, there is a deterioration in the vision, so on the left eye. And lost follow-up till 18th of April 2022. This again more than 1.5 years, the vision, but still we are having a medication is working for cataract. We can solve it anytime, but if we didn't treat the diabetic macular edema and not giving this a long-acting steroid, maybe we will lose the vision completely. As you know, the DME is the most common cause of loss of vision in diabetic patients. This is how the patient looks on 18th of April 2022. I think it's fair enough for this one. Thank you very much. If there is any question.
Thank you. As we discuss, we'll take the questions later. And now I'll invite Ahmed Roshdi Al-Agwari from Egypt.
Good afternoon.
Ahmed is presenting a case of branched retinal artery occlusion in a case of COVID.
So the patient is a 14-year-old child, presented to me with right diminution of vision that was discovered accidentally. The best corrective visual acuity of the right eye was 0.3. Anterior segment examination was normal, and the posterior segment examination showed a blunted foveal reflex. So OCT macula showed diffuse thinning of the inner retinal layers in the superior part of the macula. I did for him a fluorescein angiogram that showed old perfused upper branch retinal artery occlusion, and luckily the patient had a patent cilioretinal artery that showed early perfusion in the angiogram. The other eye was completely normal. We know that the retinal artery occlusion is common in old age patient with risk factor for thrombosis or embolism. Given the patient's young age, we took a good history that revealed history of COVID-19 infection 2 months prior to this presentation, and there is no any other systemic disorder. In the literature, there is a lot of reports of central retinal artery and branch retinal artery occlusion following COVID-19 infection, but all these were reported in adults. None of them were reported in children. And from this case series of 27 young patients with retinal arterial occlusion, the most common cause was migraine, followed by coagulation abnormalities, hemoglobinopathies, cardiac disorders, and vasculitis. So I decided to do a complete systemic workup for my patient. Cardiac consultation and hemoglobin electrophoresis were negative or normal. Vasculitis workup was negative, including low pass anticoagulant, antinuclear antibody, and anti-double strand DNA. Thrombophilia workup was also negative, including protein C, protein S, antithrombin 3, factor 5 Leiden, and the homocysteine level was normal. But interestingly, the homocysteine level was at the upper limit of the normal range. That's why our hematologist asked for genetic testing for prothrombin gene mutation, which came back normal, but the methyl tetrahydrofolate reductase gene mutation came back positive. So what is the MTHFR enzyme? This enzyme is responsible for remethylation of homocysteine to methionine. If this enzyme is disrupted, the homocysteine level will increase, but the gene may have a mutation leading to mild decrease of the enzyme activity without significant elevation of the homocysteine level, such as our patient. In general medicine, there is a controversy regarding this gene mutation. So some studies reported that it is not associated with any vascular events, while other studies reported association with systemic vascular events and coronary artery disease. And also in ophthalmology, some studies reported that retinal vascular occlusion was associated with mutation of the gene of this enzyme, while other reports didn't find any association between this mutation or this polymorphism of the gene and the vascular occlusion. And the variability of these results may be explained by difference in inclusion criteria, sample size, ethnic background, gene environmental interaction, and other confounding variables such as smoking and cardiovascular disease. So now at this moment I was very confused. Is this artery occlusion related to COVID-19 or it is related to the MTHFR gene mutation or related to both of them? The decision was very difficult because I did not see the patient during the COVID-19 attack. The patient developed the artery occlusion 2 months after the attack of the COVID-19. So I was still confused, but I was confident to suggest the COVID-19 infection and the MTHFR gene mutation as the cause of the branch artery occlusion in this child when the group from Bascom-Palmer published this case report of central retinal vein occlusion associated with COVID-19 and the MTHFR gene mutation in a 15-year-old male. In this case report from Bascom-Palmer, the central retinal vein occlusion developed during the attack of the COVID-19, and all lab investigations were negative, including homocysteine. The child only had the same mutation as my patient. We know that the COVID-19 may be exposed to thromboembolic events due to excessive inflammation, endothelial dysfunction, and platelet activation, but it seems that there is increased risk of thrombosis due to the underlying systemic hypercoagulable mutation or the gene polymorphism. The activity of the MTHFR enzyme is influenced by dietary intake of folate and vitamin B12, which increase in the enzymatic activity leading to normal homocysteine level. So fluctuation of the folate level may be associated with fluctuation of the homocysteine level. And this may explain the thrombotic event while the homocysteine level is normal, because you catch the patient during the period when the homocysteine level is normal, but at other times it's elevated. So take home message, inherited thrombophilia is associated with retinal vascular occlusion and is multigenic with different factors interacting with each other. The MTHFR gene polymorphism should be tested in atypical patients, such as young patients, bilateral presentation, and family history of thrombosis. These patients might benefit from anticoagulation therapy during COVID-19 infection. And the most important thing is that supplementation with folate and vitamin B12 may save them from future thrombotic events because it increases the enzymatic activity. Thank you very much.
Thank you, Ahmed. Now, I'll invite Dr. Shahzad Shafkat, who's clinical retinal lead at Dudley in the United Kingdom. And he's going to talk about his experience with AMD and DME and POView.
Thank you very much, Bakar. I'd like to thank Professor Hakan and Professor Moeen for the invitation. I'm going to talk about Freecimab for wet AMD and DMO. Um, I'm very happy to.
Shazad, you may need to raise the mic a little. Thank
Can
you.
you hear me at the back? I bring greetings to you from British Pakistani Ophthalmic Society, which is a very proactive group of British consultants, SAS doctors, registrars, fellows, and trainees, working with our colleagues here in Pakistan, bridging the two ophthalmic communities. We are very keen to start this conversation about how to improve outcomes in patients in Pakistan, sharing clinical pathways with the colleagues here, and also to promote audit and either clinical research or at least short case series of patients that can be reported. I'm also flying the flag for Medical Retina Association of Pakistan. So, Dr. Al Mary has very clearly told you about the disease burden, and the disease burden is shared in the West, just as in the Middle East. Age-related macular degeneration is the commonest cause of partial and severely sight-impaired registration above the age of 55. Out of a population of 68 million, it affects 600,000 people in the UK, or just about 9% of the population. Diabetic retinopathy is the second leading cause of partial and severe sight registration under the age of 55. Till about 5 years ago, this was the commonest cause of blindness, but because of effective community diabetic screening, the rates have come down, and it's now superseded by inherited macular dystrophies and retinal dystrophies. We know that about a third of all diabetic patients will develop diabetic retinopathy in their lifetime, and about a third of those will have sight-threatening macular edema requiring treatment. So, roughly out of, and these are 2020 figures, 4.1 million diabetics, about 1.2 million will have a degree of diabetic retinopathy, and about 330,000 will have sight-threatening disease requiring treatments in the form of anti-VEGF injections, steroids, and laser. So clearly, we are straining under the burden of disease, not only for the society where the patients have to be brought in by their family, but the providers, the National Health Service, the hospitals, we have to cater for all these patients, all the footfall in the department, staff shortages of all levels, from consultants to nursing to injectors. And not forgetting the carbon footprint. We are very keen now, and there's increased talk of hospitals becoming fully recyclable, and also every hospital to have a degree of carbon footprint. And we know that the less patients come into the hospital, less services are required. It will also improve the carbon footprint of the hospital. So we need treatments which are long-lasting and durable. So this is an interesting slide from the 2020 EU Retina clinical survey. A question was put to all the medical retina specialists as to what do they think in their particular hospital, in their region, in their country, which are the most important things for their patients of wet AMD and DMO. And yes, 49% of them said we would like to have an agent which improves the vision as best as possible. But more than that, said that they would want something which is more longer lasting, which is more durable, that puts less strain on the community and particularly on the hospital services. So 67% said we want to reduce the treatment burden on the patient. 68% said we need more durable action. So, the search is on for an agent, the magic bullet that will not only improve their macular appearance, but also require treatment less frequently than what we already are doing. Again, this has been alluded to by our colleague from UAE earlier, that although we get really good results in pivotal studies and randomized controlled trials, but we still falter when it comes to actual real world activity and what happens in our clinics and in our hospitals. So we know that um, 2 in 3 patients, 2/3 of patients with AMD and about 50% of patients with DMO, they need intensive treatment. So, 4 to 8 weeks of treatment. And so to keep that level of treatment intensity, it's a big burden on the society. We also know that we are not actually providing the injection services as we should, as suggested by randomized controlled trials. Although we take randomized controlled trials as the gold standard, we're actually not meeting that demand. So that's where enters VEGF from its initial discovery as a molecule which promotes inflammation and swelling and vascular changes in 1989, to the discovery that an antibody against VEGF would reduce and shrink the size of gut tumors in 1993. The search was on to find a molecule which would could be injected or used in the eye, either in the form of injection or somehow get to the retina to reduce wet macular degeneration and leakage from diabetic retinopathy. So in 2007, Lucentis was approved for wet AMD, 2011 for DMO, but these were monthly injections. So if you look at Anchor and Marina, the landmark trials, they were 1 monthly injections, and no one can bear that kind of burden on their services. So we heaved a sigh of relief when Eylea got its license in 2012 for AMD and 2014 for DMO, because that was a 2 monthly injection, so we could double the duration in between hospital visits. Uh, 2020 was a big year when brolucizumab was launched, and that, we knew that more than 50% of the patients could be extended to 3 monthly injections. Of course, we ran into the storm of intraocular inflammation within a year of it being launched. And so we are very happy now that in 2022, June 2022, this was faricimab was approved for AMD and DMO in Europe and in UK. So it's the world's first bispecific or biphasic antibody. So it contains anti-VEGF portion and anti-angiopoietin 2 portion combined together by this modified FC segment of the antibody. Now, when they looked at brolucizumab, they found out that the inflammation or the pro-inflammatory part of the molecule was the FC segment of the antibody. So with this, they were very, very particular, and they spent a lot of energy and time to make sure that the FC fragment of Vabysmo is non-immunogenic as much as possible. And so far, touch wood, there have been no reports of intraocular inflammation or occlusive vasculitis with this drug. So we know that VEGF-A increases vascular leakage and promotes new vascularization and sprouting. Angiopoietin 2 also increases vascular leakage and inflammation, but not only that, it sensitizes the retinal blood vessels to the effect of VEGF-A. So with that, both of them acting synergistically, you get the dual inhibition, which stabilizes blood vessels, reduces neovascularization and hyperpermeability, which reduces inflammation and edema, So we're hoping that this drug will prove what it promises and will show a durable efficacy in real world data. So we were the first hospital in the UK to use that. So I gave the first injection in the UK, and we're hoping to follow up this with our data. So hopefully, in coming years, we'd be able to share the data with you. So normally, we have Ang1, which is produced by the platelets and parasites. It acts on the Tie2 receptors, blocking the Tie2 receptors, which does not sensitize the VEGF-A and does not increase the affinity of VEGF-A to VEGF receptor. And there are two types of receptors. It's VEGF receptor 2, which is much more important in the retina. So so remember, Ang1 good, Ang2 is the villain. Ang2 is bad. So we want to inhibit Ang2 in the retina. So with Ang1, it causes tightening of endothelial junctions. It promotes the activity of parasites, and they wrap tightly around the capillaries, and that results in homeostasis and improved um, um, improved structure of the capillaries. Whereas with the release of angiopoietin 2, Ang2, the Ang2, they block the Tie2 receptors. Hence, Ang1 cannot have its beneficial effect. And the end result is that the endothelial cell junctions become leaky and weak, and increase loss of leukocytes and migration of leukocytes from the capillaries sets up more inflammation. The parasite concentration around the capillaries drops. They become destabilized and are lost. That leads to vascular sprouting, and you know what happens, leakage and hemorrhagic activity in the retina. So this is the final common pathway for both uh, AMD and DMO. So we've heard already about the pivotal trials, Tenaya and Lucerne for wet AMD. Faricimab is called Vabysmo in Europe and America, and the VAB, V is VEGF from V is derived from VEGF, is angiopoietin 2, and B is biphasic or bispecific. So that's how the name was derived. So this is how we treat our patients of wet AMD and DMO in our department. Loading dose of 4 injections. And then you look at the baseline characteristics of the patient: visual acuity, central foveal thickness, presence or absence of hemorrhage, to the visit after the 4th injection. And then you decide whether you want to inject them at 2 monthly interval, just like Eylea, or 3 monthly injections, or 4 monthly injections. So there is a disease activity assessment visit at 20 weeks to decide how you're going to do. Whereas obviously in Tenaya and Lucerne, aflibercept was given at a fixed 2 monthly dose. Oops. So if you look at the durability of different anti-VEGF agents, we know that in 2-year or 1-year data, that about 50% of the patients can be kept at 3 monthly injections for brolucizumab in the Hawk and Harrier trial. If you look at the Eylea treat and extend trials, which weren't fixed to monthly, they were allowed to increase the interval to 3 months. About 42 to 47% of the patients could be kept at 3 monthly intervals, which is not too far away from brolucizumab. But look at this, about 80% of the patients can be kept at 3 monthly with the biphasic faricimab. And in Aries and Altair, Eylea was also allowed to be given 4 monthly based on physician discretion, depending on those biomarkers and parameters that we talked about, vision, central foveal thickness, and the lot. And around 30% in Aries could be extended to 16 weeks. Obviously, that wasn't done in Hawk and Harrier for Bearview, but look, around 45% of the patients can be kept at 4 monthly injections. So here's a drug that addresses our current issues of longevity of treatment, durability of treatment, and treatment burden. So in the UK, the criteria for starting treatment for AMD is exactly the same as for Eylea and Lucentis. There's no difference. These are exactly the same parameters that we use there. And again, no difference between starting faricimab for DMO compared to Lucentis and Eylea. They've got to have clinically significant macular edema and a central foveal thickness of 400 microns or above for us to start treatment. So this is just to show very low rates of intraocular inflammation and no reported cases of occlusive retinal vasculitis. I'll let you read this. Uveitis, very similar in the two groups of Tenaya and Lucerne. Vitritis, very similar, and no cases of retinal artery occlusion or vein occlusion. So I'll quickly move on to my next slide. So just want to share one case. This was the first case that we treated of wet AMD. A 74-year-old man with a visual acuity of 660 and central foveal thickness of 660 microns, presented with a typical wet AMD lesion. You can see subretinal hyperreflective material or SHREM, retinal thickening, retinal sub-RP, as well as intraretinal hemorrhage. First injection, 11th of July. This was the first patient that I treated, and this was also the first patient to get Vabysmo in the UK. First injection, 15th of July. Second injection, 17th, 3rd, and 4th. So loading dose of 4 injections. He was seen after that, 6 weeks after that, 20 weeks, which is the disease activity assessment, where you then decide whether you're going to give them treatment 2 monthly, 3 monthly, or 4 monthly. And this is his situation. You can see complete clearance of all hemorrhage. There is a little bit of SHREM here, a little bit of a loss of his ellipsoid zone, but vision has improved, central foveal thickness has improved, and we will continue treating him with injections. So his next injection, number 5, is planned for 21st of this month. I'll take any questions.
Thank you, Shahzad. We'll go for the questions later on at the end because we've got to get through the other presentations. And now I'll invite Jorge Rocha from Brazil.
Hello. Hello, everyone. Please open up my presentation. My presentation has 2 parts. It's my last one here in Lahore, and I'd like to spend some time. I have 10 minutes. I have to shorten my COVID one for 5 minutes. Okay, if you show up. I have no disclosure. The background of everything about RWC. RWC is a non-profit organization, it's not a society. And after the pandemic time, I think many people in the world met during the RWC e-lives that was there. And our meeting is in Fort Lauderdale. This year was crowd, full of people, and I think many of societies joined this. And I talked about that because this was not the first, but the second collaborative study that we are trying to do together, and this is proposed to have partners around the world. Li Wanling was the first to report COVID in December 19. He died because of COVID. And COVID was pandemic. And what is COVID? It's a virus. They call corona just because the surface like a crown. It's a small virus but has a high mutation rates. And then many reports they have published saying that we have COVID in retina. The first one was a Brazilian one that we found just exudates on the retina. Maybe it was not COVID. I have many discussion about these papers around the world. And other ones, like this one, that's atypical lateral COVID, was published, and the patients had COVID and had this multifocal choroiditis. Maybe it was just because the patient was predisposed to have choroiditis, not because of COVID. And this old wine, new bottle is because the guy had cirrhosis, central cirrhosis, during the time of COVID. But the guy had a lot of steroid, intravenous steroid, during the treatment, and maybe it was just coincidence. And another one has occlusion with COVID, but occlusion also is very prevalent. We don't really know that it was by chance or not. And then, why you just think about COVID and occlusion? Because we need this triad that make the endothelial lesion with blood flow. That thing can happen in COVID because they change the complement and have fibrin and everything. And we have this lesion in the vessel, and the lesions may cause this. But if you think about the vaccine, 12 billion doses or more was give around the world, or so large. And we have more than one type of vaccine, or 4 kind of vaccine. And each one has a different mechanism. And main ocular effects, side effects, was reported, many. And it's not central cirrhosis. And venous occlusion is one of them. And we try to work on that. Try to describe a series of cases that was venous occlusion after the COVID vaccine. And then, this is my co-authors around the world. And it started November 29. Wow, too fast. And the inclusion criteria was something that happened before 30 days. And the study data still go on, we're not closed yet. The result, we have 10 patients in 5 countries, 7% female. The average day was 15 days. BRVOs, CRVOs, and 8 RVOs. And most of this vaccine was AstraZeneca. We don't know if has any relationship, but 40% has systemic factor like hypertension, diabetes. Only 6% has none. And the most frequent vaccine was the AstraZeneca. And just one case, the 53 years old male that has CRVO 2 days after the second dose of vaccine. She was 2200. She got three shots of anti-VEGF. It got better. And then, vaccine has highly effective, well tolerated around the world, any kind of vaccine. And few patients experience adverse event. I look at the trials, they say 10 to 30% has some mild or not mild adverse event. Retinal vasculitis is something that was published with influenza vaccine, mainly in females and elderly. 7% of all was women. Vaccine-related vasculitis has been previously described in many other vaccines. RVOs is hypothesized result for hypersensibility and deposit complex of complement and any lesion in the endothelial cell. Event might be related systemic risk factor as well, hypertension, diabetic, but 6% of the case has no risk factor, may be related. And this big series of case, 11 million patients, was described with thrombose, venous sinus thrombose in UK, huge number. This has count because it was not something that we can do easily. And in Brazil, we have the serious case that we look for after vaccination. We have occlusion, but not only venous occlusion, what's arterial occlusion, and was not well described. But we think that we have very small number of patients for different countries, different type of vaccines. RVO is something not rare. We can get anytime. We never had so global scale vaccination like this. And then our data that showed that shortly after COVID, vaccine suggests possible temporal association. But it's something that we have to think. If you look all around the world, we get only 12 cases. It's very few. 12 billion or more people was vaccinated, get shot. It's very difficult to say vaccine cause venous occlusion. Our think is that. But now, it's my last talk, and I'd like to tell a history. The first history is about this guy here, the chairman. I first met him in 2016, and he invited me for a SARIV meeting, Argentina Retina Society. And it was in Iguazu, but it's a river with the Cataract Falls. One side is Argentina, the other side is Brazil. And the first social recognized of the Argentina side, we are in the side of Argentina facing Brazil, the other side of the river. And somebody asked me, oh, you think Brazil is better, no? There, the vision of the falls is much better than here in Argentina. I just think, no, it's just different. It's not better or worse, it's just different. And then I'm still friend of this guy. Since that, we travel together, and I hope I could still friend until my end of days. And another thing to tell you about this girl. Yes, I remember. 1 minute. This girl really tried to teach me how to be Pakistan in 1 minute. She approached us, asked for a picture, start to ask things like, where are you from, what you are doing here, and look her hand. And then, I think this is the spirit. Friendly people, hard work, intelligent, that's huge hospitality. And the other lady, Emila, I don't know if she's here, was some person very energetic, friendly, and she cut over of us with energy, sympathy. She was the spirit of the diversity. She's from Bosnia, and she make us happy every day because she's a happy woman. And then I came here, I have to confess, it was not easy to decide to come here. My wife, at first in 2020, when I was first invited, she said, no, you can't go there. It's dangerous. All the news that we got in Brazil about here is fake news. We don't know anything that's happening here. And then I said, I go. And I was very anxious to know what to expect here. Don't know what to expect. I don't know what I'll face here when I arrive. I just know this guy and the Mexico, Dominicana guy, the Latino people that I invite. The other people I know just by virtual space, like my friend Tatiana, Nur, and I got here and found so many good people. So many good people that I met and make friends, exchange, learn a lot, and see how good to make friends and get along well. This trip changed me. I think changed many people here. And everything, I have to thank this guy. He's a dreamer. He make the dream come true. He invite me, insist. Many times I say no. He said, no, you should come. And then, after a while, I'm here. I'm really happy to be here with you. I'm really happy to open and learn and make friends and cooperate with anything. I have to thank everyone here, the attendees and my friends from different countries that just got me with open arms. Thanks so much. To be here is speechless. Thank you.
Thank you, Jorge Rocha, for your nice talk and your lovely sentiments. Dr. Naveed Ishaq from Rawalpindi is next. Naveed Qureshi, sorry.
Thank you very much. My talk is about a new drug, anti-VEGF, just new in Pakistan, and that is Conbercept. This is a Chinese drug, and just arrived in Pakistan. Very limited experience. So just I want to share a few cases about this drug and outcome. So, Conbercept actually, this is a fusion protein of human VEGF receptors, and it has affinity to bind both FC1 and FC2 fragment, and also with VEGF A, B, and placental growth factors. So, initially, because this drug is not FDA approved, so we were anxious to use this drug. But after reading many articles, and I decided to use this drug in a few of my patients to see the outcome. So these are the patients actually already received many other anti-VEGFs, and especially they are not getting any response from the previous drugs. So I decided to switch those patients to Conbercept. So why Conbercept? Relatively cost effective as compared to Lucentis, as compared to Eylea. It's relatively cost effective here. And the low dosing regime, because this drug.
Sorry,
Sure.
just to know, how much does it cost?
Around 50,000 PKR. Yeah. So the other one is 90 or something like that. And the other thing is that If after 3 injections monthly, we can shift to the 12 weekly injection, especially in the new vascular AMD cases. So we can switch to the 12 weekly regime after 3 loading doses. And the other is that we have another options. So this is add-on. The previously we have 3 anti-VEGF available in Pakistan, and this is the fourth one. So this is my case, first case. 65 years old male, bilateral exudative AMD with best corrected vision acuity in right eye 360 and the left eye 618. Very extensive submacular hemorrhages, exudation in the right eye and the left eye. Also, there is CNV, PED, and there is some fluid under the retina as well. So this was the case which was not going to respond with the previous anti-VEGF. So I tried to give injection of this conbercept in this case. So after first dose, you see slightly improvement in the fluid, but still there are large PDs and subretinal hemorrhages as well. And after the second dose, vision improved, but the patient did not, on the OCT, will not see any much uh, remarkable improvement. But these are the fluid which resolve, but still there are large PDs, same in the left eye. But if you see the fluid resolved, visual acuity improve in the right eye in the 6 by 36 and the left eye 612. So patient is relatively happy, but still under treatment because this drug launched 3 to 4 months before. So we keep an eye on this patient and we'll see. Probably we need another injection, but after third injection, I'm now planning to increase the gap, treat and extend, and go for the 8 weeks interval in specific case. Case 2 is this is a young female. This is a case of choroidal osteoma with secondary CNV bleed and submacular leakage. She's I am observing this patient for the last 5 years. First time she presented to me in 2017, and then at that time vision was okay. And then later on she developed CNV in 2019. Then we inject anti-VEGF. Initially she responded, and then after every 3 to 4 months, she again come to me and with the bleed. So this is a rare case of choroidal osteoma with a bleed in the that area, and patient come with the fluid under the macula. And every time we inject, but after 2 3 injections, 3 to 4 injections, the she was not responding very well with the anti-VEGF Avastin and with the Lucentis. It comes with the name of Petizra in Pakistan. And then we switch to this conbercept in this case. So this patient behaved very well, and after injection the fluid absorbed, and the hemorrhage clear, the macula become clear after single injection, and the visual acuity improved to 6 by 6, particularly in this case. And patient is still under observation because these kind of cases, osteoma is still there, so there is chance of rebleed. So I switch from other anti-VEGF to this anti-VEGF because previously the other anti-VEGFs were not working at last 3 4 months. This is another case having diabetic macular edema. Again, this is a 57-year-old male, severe NPDR with DME in the left eye. In the right eye, patient has corneal opacity and XT, lazy eye. And the left eye, already given 3 Avastin and 2 Petizra. But he is not getting any response in this case. So one injection of conbercept was given 2 months before, and after 1 month, there is no change in this particular case. Edema still there, vision still there, no improvement. Patient is well controlled, diabetic. The rest of parameters are normal. So again, I'm thinking either to give another injection. I did not try Eylea in this case, or I will go for another same injection this month, and then will decide after that what to do. So it is actually very limited experience. So just to share with this about this molecule, but this is in the process of FDA approval. Until that, this is approved by in the DRAP in Pakistan. There is a DRAP, Drug Regulatory Authority of Pakistan. It is approved here with limited number of cases we can do. First, we have to inform the DRAP we are using this drug to a particular patient, then they allow us, and then the injection will be available for us. So larger study obviously required to conclude its efficacy and disease-specific indication. Thank you. Any question? Thank you.
I think. Okay, I have my talk, but I think it overlaps a lot with your talk, Shazad. So I think it's better if we can talk each other, you know. And I wonder. I'm going to use my minutes to make my question, and of course, if you want to do your questions.
Sorry.
Yes.
I think there are a couple of talks more.
Yeah. Oh, I'm sorry. I didn't. Let me. Well, fantastic. Well, I'm so generous that I'm giving my time to.
Do you have a
I'm sorry. I hear. No, okay. No. You. Please. I want to hear you. So that's fine. Because I'm not reading
So I'm not sure how we'll get to that. I'd like to welcome Dr. Ijaz Sheikh from Red Hill, Surrey in England.
Assalamu alaikum. Welcome to the guests. I'm a guest as well, but because I'm a native Lahori, I keep coming back. And there's a saying about Lahore. Jine Lahore ne dekhe wo jamia hi nahi. If you haven't seen Lahore, you are not born yet. So you are all born again. And I keep coming back every 6 months, 1 year to be reborn. So welcome to the Lahori community. Lively city. Used to be even very, very, what we say, gardeny. It's city of gardens, encroached by everybody, but still the people are the same. Very open, very lively, welcoming, hospitable, and always welcoming anybody who comes in. So I hope you will come back to visit us time and again. And especially thanks to Professor Hakan, who has been instrumental in developing this great program. So that's related to my talk as well. It's about pregnancy. So we are reborn. So it's one thing which we don't talk much, actually. We had a grand round in our hospital. My trainees asked me, can I present a case, which we saw a few weeks ago. I said, why not? And then there was so much of inquest from the women's health team, gynecologist and obstetrics team. I said, okay. I have read about it, the guidelines which have come through from the Royal College of Ophthalmologists. So let's make it more presentable. So this is the reason I have just narrated a bit more about it. So it's a case study of a 32-year-old female who presented to us with reduced vision. She was 15 weeks pregnant at that time with reduced vision of 6/18 right and 6/12 left. So this was the retinal photograph and the OCT. You could see it's a background diabetic retinopathy. We have very robust national diabetic eye screening program in UK. And they have guidelines for every condition. Children above 12, for pregnancy, for other bits, and how you're going to manage. But there is a lot of versatility. People don't follow the line in a particular way. Everybody tends to think, okay, we can manage, we can skip. But it is important. They have a consensus group, which I will relate to when I move forward. So she came back 4 weeks later with reduced vision of 6/36 in both eyes. Very upset because of pregnancy, because there's a lot of pressure, and is it going to affect my baby or whatever? And this is what happened within 4 weeks. Very rapid progression. So we know that grading of diabetic retinopathy, background diabetic retinopathy, proliferative, it can develop into vitreous hemorrhage. So it is very important to pick up, individualize people who have referable diabetic retinopathy according to the screening program. Every country is doing it. But the problem is we have so many classifications. We cannot integrate what to do. So this is one slide which just shows levels what were used in ETDRS initially. We have this ETDRS chart or logMAR chart based on that. The USA has 6 levels, UK has 4 levels, but in UK, National Screening Program has 3 levels only. Yeah. This one? Thank you. So they have 2 levels for R1, R2, and then R3. That has also developed into R3S when it is stable after PRP, or R3A when it is active. So we have to see and treat them within 6 weeks period. And generally, this is pre-proliferative. We see them within 13-week period. So this is a basis I thought, okay, I can talk about what is a classification. And on that basis, we know the pathogenesis is very diverse. Inflammatory mediators, angiogenic factors. And I won't go into details and show more fancy slides. Just move on to what was done by the UK Consensus Working Group. It published its findings 2 years ago. It's a very detailed document to look at, really. They have published about retinal vein occlusion as well last year. And the top-notch medical retina consultants, they joined together, sat, they picked up the common things which could be used for optimizing the management of diabetic retinopathy and diabetic macular edema. And the other thing is, since the usage of OCT on regular basis, this classical clinically significant macular edema, when they will talk about thickening of retina located within 500 microns, hard exudates, or exudate within the macula, that has changed to OCT classification, and we talk about central involving macular edema or non-central involving macular edema. And moving forward, this is a summary which was proposed by the consensus group of medical retina consultants in UK. They talk about if there is focal leakage, 500 microns from foveal zone, avascular zone, focal laser can be applied or just observe. If it is less than 500 microns, you can still observe if the vision is good, or you can go for pharmacological therapy. And if it is diffuse leakage, we can either watch or do the grid or modified grid laser. And then when it comes to central involving diabetic macular edema, so the chief level or considerations were to look at the level of visual acuity. If somebody is 6'6", we can wait. Because it is a disease of inner retina, it won't progress very quickly. It's unlike AMD, when the people can lose their eyesight within 2 weeks, 3 weeks period. And then the central subfield thickness on the OCT examination was also very important. And we have to look at the patient choice. We just can't say, okay, you do this, and we'll start giving you the injections. I had a patient very recently. He came with vitreous hemorrhage. He was a heavy goods vehicle driver. I told him, this is your prognosis. This is going to happen. You will lose your driving license because I will be giving you PRP straight, and your other eye is pre-proliferative, but I will treat that as well. So you may not be able to sustain your driving license. He frightened. He had first session. At second session, when I had a look at it, he said, I have lost half a stone already because I want to carry on with my profession, because that is the issue we have with diabetics. They're young people, they're in profession, there's loss of quality of life, and their earnings. They can't come to the hospital. Compliance is, that's why, so poor. They don't have to time. Either they can earn their bread or they can come to the hospital for treatment. So that is a real big issue in diabetics.
I'm sorry, I don't want to interrupt you.
Yeah, sure, please.
But I think that you in the UK
UK, you are very, very, in the UK, they are very, very good in health policies, but I wouldn't follow that if it were my eye.
I know. My brother, my class fellow Shehzad, mentioned about it, how we have to work around the number of injections and other treatments we have to give. It's not ideal. We struggle all the time. That's why I decided I will cut down my work. I need to calm down because I have had too much on my heart to carry on with the amount of work we have been doing. It's non-stop, non-stop. And we know the demand is increasing. So we need to find other ways. That's why brolucizumab and Vabysmo and maybe giving suprachoroidal steroids, whatever is good, we can choose them. Then we have this NICE, National Institute of Clinical Excellence, that is the body who guides us what to do. And they are very bureaucratic. They won't budge. And similar is with the diabetic eye screening program. They have a very robust program. And I'm giving a talk about that tomorrow. We are doing a research project which has been approved by National Institute of Health Research in UK. We're looking at the predictors to pick up patients who are at high risk of losing eyesight and individualize them, separate them from the normal people, because 50% are false positive. So tomorrow, I think it's around 11 o'clock, I have a talk. I will discuss what we are doing through that. So what happens? Incidence is increasing because more and more people are becoming diabetics, and they are having later pregnancies. They say, okay, we can wait, we'll have it when we are in 30s or later, doesn't matter. But they come up with all the other issues as well, like Downs and other health issues with the babies. And the other thing is prevalence of diabetic retinopathy is increasing. Gestational diabetes, 10 to 27%, quite high. And type 2, 14%, but type 1 is quite high, 34 to 72%. We know the incidence is there, but if it is type 1, they have more sight-threatening problems, especially the proliferative diabetic retinopathy. So what are the risk factors? Duration of diabetes, we all know about it. Metabolic control of diabetes, baseline severity of diabetic retinopathy, hypertension, and more importantly, what was the visual acuity at conception, and what was the level of diabetic macular edema at conception? Because a lady I mentioned about, maybe she was developing a bit of macular edema already, and it was only picked up when she lost her vision. And also the age of onset of diabetic macular diabetes. So investigation-wise, we can just go ahead with fundus photography and OCT. We can't proceed with FFA and ICG because of the health risks. As mentioned earlier, good control of diabetes, hypertension, and anemia can reduce the diabetic macular edema. We'll keep seeing it regularly. Patient education, leaflets, explaining to them, frighten them to death. Okay, this is what is going to happen if you don't behave. And in UK, actually, there are pockets where there are non-white people. Both husband and wife are working, and they are dependent on what we call takeaways, and that is rubbish. We know KFC and McDonald's, they have increased our diabetic levels. It's so easy, and look at the level of calories we take in. So grid and focal laser can be applied. Micropulse laser is there. We have other lasers like which can integrate your OCT with the laser and steroid injections. In the UK, we don't do suprachoroidal. We would have preservative-free intracinol and Ozurdex. For quinolone, we have tried, but my experience has not been so good. They develop very severe glaucoma, and it is usually not easy to manage. PRP laser is still the standard, and I am very keen on PRP now, again, after giving some injections in the past. And in severe cases, surgery can be done. So anti-VEGF in pregnancy, safety is not established. It can be given immediately after delivery because it can have still benefit effect. Best to delay if the patient is already on anti-VEGF injections, the pregnancy. So what is our role? Retinal examination, digital examination at first antenatal visit and 28 weeks of gestation. And if it is nothing serious, keep seeing them. But the issue is, the question we get is misconceptions. We should not bring the blood sugar level rapidly low. It is not actually. It may be initial worsening, but then eventually patient do better in the long run. Same, they can develop mild proliferative, mild diabetic retinopathy. Don't bother about it, but they can progress. They should be followed up at least 6 months after delivery. Another one is, can vaginal delivery be done? It's a quite commonly asked question from the obstetrics to us. They say, okay, there's no harm actually. It's not a contraindication. Just warn the people. If vitreous hemorrhage happen, we will manage that. But why to have a major operation which can be delivered normally? So another question, how old you are when you're pregnant? But having pregnancy early in life is better than having it delayed. So I will just rush through the rest and take-home messages. Diabetic women are at risk of developing progressing diabetic retinopathy in pregnancy. They must have first antenatal visit and 28 weeks assessment. Treatment modalities are available because we want to prevent permanent sight loss. Thank you again, AACO, Ophthalmic Society of Pakistan, and my own organization, British Pakistani Ophthalmic Society, which have been very instrumental in helping and providing lectures and fellowships and other things, and online fellowships as well. Thank you very much.
Thank you, Dr. Ijaz Sheikh. Now, we have one last talk by Dr. Shakib Anwar from Islamabad, and then I'll request Mario, because he has to rush to another talk.
Don't worry, actually,
Yeah, we'll just ask you to sum up and, yeah.
So, Bismillah ar-Rahman ar-Rahim. It's just actually, it's the last talk of the day and everybody's tired and the population is thinned out, so people are tired. So, but I'll try to be brief. So we begin with the name of Allah. My talk is on fixing age-related macular degeneration at its root. So it's everybody knows that it's a leading cause of blindness, especially in age of population about 50 or so, and it has a multifactorial disease: age, smoking, exposure to sunlight, and genetic influence is there, and it entails repeated hospital visits, multiple injections, and risk involved is immense while doing these procedures. Currently available treatments: anti-VEGFs, lasers, antioxidants, and healthy lifestyle, but these are mostly for wet macular degenerations. Unfortunately, there is very little choice available for, generally no treatment is available for dry type of AMD. So because of lot of burden, so lot of burden on the society, new treatments were coming up, and which are longer acting anti-VEGFs, biosimilars. ये आपका चल नहीं रहा, नहीं पॉइंटर नहीं चाहिए, ये नहीं चल रहा, फॉरवर्ड नहीं कर रहा, कभी करते कभी नहीं कर. So biosimilars अभी देखे नहीं कर, and new delivery system, and then we have gene therapy. Now this is something which is a promise for future. Now if we look at the milestones in the gene therapy and the history of gene, In 1866, it was Gregor Mendel who first discovered genes and the very famous peanuts and all that. And in 1970, the concept of gene therapy was considered as a treatment of genetic diseases in human beings. Acha. So in 1989, it was Steven Rosenberg who was first officially approved to use genes in the human beings. And in 2017, gene therapy clinical trials were completed and ongoing, and approval was given worldwide. In 2017 to 19, United States approved the first gene therapy in human beings. Next. But there are certain key questions how to use gene therapy in the eye. Why gene therapy for AMD? Is eye suitable for this? Yes, eye is very suitable because it has got different compartments. So you can deal with the posterior segment and you can still save the anterior segment, and it may not be transferred to the blood. What would be the aim of gene therapy and what mechanism will be applicable? What have we discovered so far? Any success so far, and what are we expecting in future? Next. So pathogenesis of AMD is more complex as compared to monogenic inherited diseases, and initially 4 genetic pathways were identified, as Dr. Amri also said: complement fixation system, lipoprotein metabolism, angiogenesis, and extracellular matrix remodeling. Next. So these were attacked first. And the protein, recently it has been found that there is a protein altering variant of collagen 8 alpha 1. This gene has been identified affecting collagen type 8, which is found in the Brooks membrane. Now, if this gene is malfunctioning, then a portion of the Brooks membrane is also malfunctioning. Similarly, loss of enzyme RNase dicer1 has also been found less or missing in such people, which directly affects the atrophy of the retinal pigment epithelium and its leakage. Next. So gene therapy targets the biological pathways leading to disease, dry or wet AMD. And in this we try to fix that portion of the gene which is either missing, so we add, or if it's diseased, we try to replace it with a healthy one. And how it is done? Next. So there are 4 ways. Either you replace the gene, or you add a gene, or there's a gene inhibition mechanism that you silence a few genes, or you edit the genes, that you change them or you modify them. So in replacement, you give the cell a new working copy of a missing gene, and that starts making a protein, which are an enzyme or whatever. And in gene addition, a new gene is created and injected into the cell. And gene inhibition, RNA inhibitors therapy utilizes synthetic RNA that can find and inhibit certain sequences of harmful genes, and it can silence those genes which are causing harmful effects. And in gene editing, allows to make precise changes. So you cut the disease part of the gene like scissors, and you replace it with a useful gene. Next. वापस कीजिएगा, वापस कीजिए. हाँ. All right. So this is a simple model how it works. Actually, so this is how the vector is a virus, and it is adenovirus vector 8. It's a modified virus in which is loaded with the gene or the portion of the genes. It goes into the cell, it's packaged in a vesicle at the cell wall, moves in and goes into the nucleus and releases that part of the DNA, which is ultimately fixed here. The other one is cut and the new gene is fixed here, and this is called gene editing and gene fixing, like this. So, all right, this is again little short video of how it enters into the cell, and then it goes to the nucleus, then the single-stranded form, and second, and on. So CRISPR is the technology which is gene scissors actually. It's clustered, regularly interspaced, short palindromic repeats. What they do is that in bacteria, when bacteria are attacked by viruses, what they do is the bacteria has got a protein which is called Cas9 protein. So it makes copies of the specific portion of the DNA of the virus and then remembers it. The bacteria remember those viruses. So next time when they attack, this Cas9 protein goes and cuts those part of the DNA of the virus which are harmful. So we use in genetic studies that Cas9 protein from the bacteria, borrowed from the bacteria, that is used as the scissor. So with the Cas protein, we load the gene part that we want to enter into the nucleus, we load it, and with a guide RNA, it goes into the nucleus. The diseased part of the gene is cut and the new gene is introduced, and then is the production of healthy gene. And this CRISPR technology is now coming up. It's now in the vogue, and it's out of research now. It's in agriculture and everywhere. All right. So there are certain ongoing gene trials. So there are 5 trials going in different, already been mentioned. The first 2 are very important because they have passed through the phase 1, 2A. Phase 1 is actually when you test the safety of a new drug, and 2 and 2A are the one when you start seeing their efficacy in animals or in human beings. So RGX 314 and Adverum 22, they have gone through these trials, and they are basically for the wet type of AMD. And what they produce, the anti-VEGF antibodies they produce, and the VEGF produced in the body is killed by itself, body's own antibodies. So they help the anti-VEGF drugs also, like intravitreal aflibercept and all that. There are only 2 genes trial which are going for non-vascular AMD, that is dry AMD trials, and they are HMR59 and GT005. They are also passing through phase 1 and 2 trials, and they can be intravitreally injected, some of them, and it can become an office procedure. So once you inject them, what they do is they transform the retinal pigment epithelium, they transform them to start producing certain either antibodies which would kill the naturally occurring VEGF, or they will help or augment the anti-VEGF given to be more effective. So these are the explanation of all these. ये नहीं चल रहा, फिर नहीं चल रहा, चल नहीं रहा. So that was all. There are some other new revenues which are coming. Pluripotent stem cell transplant. It's an older one, but sometime it becomes in vogue and then it dies down. And then these are the cells, and the retinal prosthetics like Argus 2. This year, retinal surgeons know it, that it's a very technique is very novel, and which a small camera is fitted onto the glasses, and the camera sees the pictures. Then there is a transducer which turns the visual scenes into impulses and electric signals, and those signals are wirelessly, they are transferred to a small chip in the retina, and then that stimulates the viable or the living nerve cells of the optic nerve, and they start kind of Morse code given is there, and ultimately it goes to brain to produce a picture. The others are intraocular implant releasing ciliary neurotrophic factor. This is what the ischemic thing, that ciliary neurotrophic factor is released through a long-acting device like Ozurdex, and that might help. The studies show that the retinas are more responsive in people who have been injected this. So until recently, at the end, CRISPR, the gene editing technology, sounded more like a science fiction than medicine, snipping out problematic DNA. But soon we saw regulations approve the gene editing technology in an effort to combat rare inherited blood disorders that affect millions of people on the globe. And drug discovery is a long and unpredictable process. But the impact that gene editing can make in drug development is getting clear. The targets we are finding with CRISPR will guide the development of new drug in this very decade. So we are expecting that within 10 years we'll be having capsules like this, and you just take the capsule and probably it's going to fix your disease. Thank you very much.
Thank you everyone for attending and participating. Are there any questions for the speakers here? We still have Dr. Shahzad Shafqat, Dr. Ijaz Sheikh and Dr. Ahmed here who can answer your questions.
You mentioned about COVID-related branch retinal artery occlusion. So, was your case also not COVID? Yeah, okay. So he's not here then. The presentation about COVID, that gentleman is not here?
He's gone.
I wanted to ask him if that was seen in somebody who had a particularly nasty COVID infection, or was it just like a regular COVID infection, and this just happened 2-3 months afterwards without any explanation?
It might just be incidental that he had COVID because he had raised homocysteine levels. So we could go down another path.
Yeah.
So there's something which could be debated, but he's not here to answer.
Any questions about
Any
Faricimab?
comments? So we've discussed the use of BioView, we've just discussed the use of Bevismo, and we've used Lumitin as well, which is Chinese. So 3 more. I'd like to ask the presenters whether is there any significant efficacy? Dr. Ijaz, you're working in the NHS and using these new drugs, and I'd like to ask you, because we don't have them here yet, is there any significant efficacy over the present drugs that we're using here?
I think Dr. Naveed Qureshi mentioned about Convercept. I think that's an excellent drug actually. If you can give.
But it's still not registered with the DRAP in Pakistan.
But that's a problem because Americans.
Have you had occasion to use it in the United Kingdom?
No, not this one. But Brolucizumab is available. And now Shahzad has started using Bevismo, and I think I will go for that because less incidence of retinal vasculitis, less inflammation, and because I'm still concerned about Brolucizumab, I haven't tried it.
And
because I can't handle that.
There's a very important aspect that Ahmed highlighted, that the use of steroids, whether intravitreal or subtenon, in conjunction or in replacing the anti-VEGFs where the cost effectiveness is an issue.
Yeah, I think we need to look at the 3 main diseases. AMD, diabetic macular edema, and retinal vein occlusion. These are the major pathologies we deal with. To me, AMD is a bit more straightforward. The worst is retinal vein occlusion, especially the central retinal vein occlusion. Whatever you do, they don't behave.
Right.
They carry on because the blood vessels are incompetent.
Ahmed Rushdie is here,
yeah.
So we can ask the questions that you were
But combination
intending.
therapy, it should work because it is just not anti-VEGF. They are inflammatory mediators as well. So we can manage them.
Thank you. So we'll wind up the session with a couple of comments.
So my question was about your patient, the branch retinal artery occlusion post-COVID. Was there anything particular in that patient that they had a particularly nasty type of COVID infection? Were they hospitalized with COVID, or did they like have, just a little bit of feeling unwell and fever? Did they have a lot of respiratory symptoms?
He was not hospitalized, but the disease also was not mild, so it was like a moderate infection. And he was tested for COVID, and he was was COVID positive. He was tested, and the test was positive, but he was not hospitalized. He didn't develop any major respiratory problems.
And the homocysteine levels, is that something which was looked at separately, or do you think
Yeah,
it's
so-
related to COVID?
No, it is not related to COVID, because this homocysteine level was tested 2 months after the COVID infection. So, and it was normal, but it was just at the upper limit of the normal range.
Upper limit, yes.
So, in the literature, when you looked at the literature, was there anything in the literature to say that, these are specific things to look out for? And, here's a cohort of patient who developed branched retinal artery or vein occlusion, and this was a common denominator in all of them, that they all had, X, Y, and Z. Was there anything picked up by that literature review?
So in literature, in testing for this gene is suggested for patients with a family history of thrombophilia. So if there is any history in the family for thrombophilia, and there is a typical presentation of the patient, you should go for the genetic analysis. Like our patient, the main atypical feature of our patient was the young age of the patient. So it's very strange to get the artery occlusion in a child. So if you have an atypical presentation, if you have a strong family history of thrombophilia, then you go for testing for the genetic mutation. But if you don't have a strong family history, I think it will be not necessary.
So did other family members also suffer at some stage
W-
with the branch vein artery?
No one in the family.
So no one in the family, but just this young person.
Yeah, this is again.
And were the other family members positive for this gene?
They never tested it.
And would you have treated this person any different? I mean, from the gene point of view, okay, you know that there is genetic predilection for having.
So the issue is that the hematologist told me is he should be careful when he does any surgical intervention in the future. So when the patient should go for any surgical intervention, maybe he will receive a short term of anticoagulant before major surgical intervention,
Right.
to decrease
so
the risk of
we'll have to
of
wind
thrombosis
up
after.
because the next session is about to start and the participants are coming in.
Can I just quickly
Please.
your query about brolucizumab? So, sorry, Combacept. Combacept is being studied in America. The trial is called Panda 1 and Panda 2 because it's a Chinese drug. Sounds discriminatory to me, but there you go. And I think the results are going to be announced next year. So this is a Eylea biosimilar, and we will know whether it's effective or not. The treatment is exactly the same regimen as Eylea.
But my point was, is there any significant
so yes,
efficacy
your other point
to
was
switch to this
about
drug?
yeah, that's right. Your other point was about
Steroids.
better vision. You said whether
Yeah.
is more efficacious vision-wise. No, all the trials, Hawk and Harrier and Lucerne and Tenaya are non-inferiority trials. So the non-inferiority trial was not testing for better vision, and in fact it did not show better vision, just that the drug was more durable and was a better drying agent. No change in vision.
So exactly what we're teaching our students, that we shouldn't treat the OCT or the fluid and the picture. So in effect, we are actually doing so.
We are in fact doing it. It's just that we have slightly more tolerance for intraretinal fluid in DMO than in wet AMD. We're still trying to dehydrate and get rid of the fluid in wet AMD as much as possible. But you have the fluid trials, the fluid study. It had its shortcomings, but it did show that you could leave a little bit of fluid, and there is some evidence, not very strong, not level 1 evidence, that if you leave a little bit of subretinal fluid, you get less RPE and photoreceptor atrophy. in the long run.
Yes,
but
that's
still,
been
there is
done.
absolutely no denying that if the patient needs 1 monthly injection, you go ahead and give 1 monthly injection. You don't hold back for fear of atrophy. And I think that was one of the drawbacks of the CAT trial, because they put too much emphasis on atrophy with monthly injections. Thank you.
Thank you very much. Thank you, all of you, for coming and participating. Thank you.
Can I just say there's a retinal debate next door if you're interested.